Well, thank you for being here, and thank you, Jack, for inviting me. I wanted to, most of this group knows that lung cancer is not one cancer. And over the past decade, we have really gone from one type of non-small cell lung cancer, we treat it all about the same with platinum-based doublets, to really knowing that histology is important, and then beyond that, the molecular biology of the tumor. And we've made the most progress in adenocarcinoma, where we have a number of targets that have specific treatments that help patients do better. In squamous cell, we're lagging behind, but hope to get more information, especially with trials like the SWOG lung map. This is the IPASS study that is now published in 2009, but I think this was the first time that we all understood that molecular testing was really important for our patients. Even though EGFR mutation was described in 2004, there was still a thought that anybody could benefit from these drugs and anybody should get these drugs. What we saw in this study, and this might be a complicated slide, but what we saw here is patients got either chemotherapy or an EGFR TKI, gefitinib. The patients who got chemotherapy or gefitinib, the patients who got gefitinib or chemotherapy who had EGFR mutations, those are in the solid lines, the solid red and the solid blue. You see, at least for the first 6 months, they do similarly. Those who had no mutation and got chemotherapy are all up with those patients who had mutations. Those who had no mutation in EGFR and got gefitinib did poorly. And so not only are we going to help people if we give them the right therapy, we could harm people if we give them the wrong therapy. And that's a problem. And now we know that some of these patients probably had ALK, they probably had ROS1 or other targets, and so that is not the right therapy for them. So we need to know the molecular background of the tumor in order to give the right therapy and get the right responses. And so when we give the right treatment for an oncogene-driven tumor, we get phenomenal responses. So on the left, you see the pre-treatment sample, the CT scans, or PET CT, and then the after 2 months, almost resolution of all the PET activity. But what happens in almost everybody is that at some point, the tumor acquires resistance and starts to grow. And when that happens, the tumor can spread, it can become different in different parts of the body, and can become challenging to treat. So this is a little busy slide, but shows kind of models of drug resistance that are out there, and it's probably a combination of things that we see. You can see two populations or multiple populations at the beginning, and the sensitive clones are treated and killed off, whereas the drug-resistant clones stay alive and repopulate. You can have potential cancer stem cells that allow for redifferentiation and repopulation of the tumor, even though some die off. You can acquire resistance where you have a new mutation, and we'll talk about that, how that occurs, and you have kind of a new population of tumor that can grow. Or you could have de novo intrinsic resistance where the treatments are not helpful and the cancer grows. So this is looking at types of mechanisms that cause resistance to tyrosine kinase inhibitors. And I know they'll be talking about immune therapy later too. For tyrosine kinase inhibitors, again, there's primary resistance and there's tumor factors and other pathways, there are but we're talking about acquired resistance, and there we do see changes in the pathways that that causes the tumor to grow. We see new mutations and new genetic abnormalities that occur. We see histologic transformation into other types of tumor types, like non-small cell turning into small cell or evolving into small cell, or there were some small cell carcinoma at the beginning of the treatment that's what's left behind. And then potentially other mechanisms that we aren't aware of. But there are multiple types of resistance, at least for EGFR. for our general tyrosine kinase inhibitors that we use, the majority of patients get a new mutation at T790M because this is a place where the TKI binds, and so that's a place where the resistance occurs. So it's a large percentage of the population. And then there are other types of resistance that occur that are less common, and still about 20% that are unknown, and probably a combination. And here are some specific mechanisms of acquired resistance. And so as you see, secondary mutations more and more are being described. And as we get to the third generation tyrosine kinase inhibitors for EGFR, we're seeing new mutations that occur. The interesting thing is that some of these mutations may be responsive to the first generation and second generation TKIs, and so there may be ways to go back and forth. And as far as alternate pathways, there are multiple alternate pathways, multiple combinations that have shown some benefit for patients with resistance. And then again, thinking about other mechanisms like immune and tumor microenvironment, the EMT process, and transformation to other types. So at this point, we have 3 TKIs that are approved, and pretty much for the first line treatment. And we're hoping to get the third generation TKIs approved shortly, and mostly for the resistance and T790M mutation, but they're also being studied in the first line to try and prevent T790M from occurring. This is showing the responses to the top 2 that are the furthest in development, which is ruxolitinib, CO1686. And what you see here is that the majority of the patients have some benefit. Those that are that go below the dotted line had responses. Those in the middle had some benefit, and very few patients had progression of the tumor when they had been treated very heavily and gone on to receive ruxolitinib. And when the patients with T790M negative tumors were looked at, there were less responses, but still a significant amount of benefit. And that may have to do with tumor heterogeneity or other mechanisms of action of the drug. And this is the second drug, the AZD9291, osimertinib. And again, what we see is the majority of patients have significant response. The middle panel is T790M positive. The bottom panel is T790M negative. And though the T790M negative don't have as good response, there are definitely patients who have response here. So we're excited about these drugs because they clearly have significant benefit for our patients. And when we look at these drugs, now we're starting to learn about resistance that occur from these drugs, and we're starting to see new mutations, and we're starting to understand that we can potentially, again, go back and use some of the first line and first generation, second generation inhibitors in patients who have developed some of these new resistance mutations. So the way that we sequence these things over time is becoming more and more complex, but will be a benefit for patients to have these drugs in the market. Then moving on to ALK resistance. So again, right now, crizotinib is the main first-line therapy for ALK and ROS1 translocated patients, translocated tumors. And what we know is that there's a significant benefit in progression-free survival, and though there was crossover, so not a significant benefit of overall survival, but does help patients live longer. We know there are multiple mechanisms of acquired resistance to crizotinib therapy, and it's very diffuse when crizotinib is used, and I think in part because crizotinib is not a very specific ALK inhibitor. It covers multiple targets, so you get multiple types of resistance, which is lots of other mutations, other pathways that are activated, and then again, the CNS penetration may not be as good with crizotinib. So we move on to having the second generation inhibitors such as alectinib, ceritinib, which is approved, and you get different types of mutations and other causes of resistance in these patients. What we don't know well, we do know that these drugs work very well after crizotinib and have good responses. And we know that there are many drugs out there that are being evaluated, all of which seem to have responses, and also, which seem to be more potent ALK inhibitors, and have many of them have responses in the brain also. So ceritinib is approved, alectinib is approved in Japan and is working toward approval in the US. Brigatinib is in phase 2, the X396 is in phase 1/2, TSR-011, RxDX-101, PF 3922, as we like to call it, CEP 37440. And all of these potentially may be things that, as we learn what the acquired resistance from the second or third line TKI is, we may find that sequencing these is beneficial to patients. So we know that patients who get second generation ALK TKIs can respond very well, and even those who have had progression on crizotinib. And this is, again, true with multiple of the TKIs. So this is brigatinib following crizotinib, and this is alectinib following crizotinib with a prolonged progression-free survival. The important thing, too, is that these drugs penetrate the brain much better than crizotinib and have had a lot of reports of responses within the brain. And I know that Dr. Wanakoko is going to talk about that in detail, but I think that's a very important piece that is going to change, or is changing, the way that we treat patients with targeted therapy. And what I wanted to do is not, I think the science is good and it's out there, but can get a little bit complex. So I wanted to bring this out into cases and talk about a few cases that I've seen in the real world, and it kind of, it might help our discussions and resonate with other cases that other people have seen. Because resistance isn't one thing. As you see, it is relatively complex. And so one tumor's resistance is very different than another tumor's resistance. And then when you get multiple treatments along the way, the tumor heterogeneity becomes incredibly complex. And so a tumor that's growing in the liver may have one type of resistance. A tumor that is stable in the lung may not have that. A tumor that grows in the brain may have a different type of resistance. And so we need to consider that. So this is a 72-year-old male, had posterior rib pain and dyspnea on exertion, had a large left pleural effusion on chest x-ray, had a CT scan, showed the left pleural effusion and some multiple bilateral pulmonary nodules. A PET scan showed the uptake in the left lower lobe and in the left chest wall and extending to the left 11th rib. The MRI of the brain was clear for metastases. He underwent thoracentesis, was found to have metastatic adenocarcinoma, TTF1 positive, NAPSIN-A positive, CK7 positive, CK20 negative. Molecular testing demonstrated an exon 21 mutation in the EGFR gene. He was staged at T1 and XM1B for the rib lesion and the malignant pleural effusion, and went on to initiate erlotinib as first-line therapy back in 2013. Had an excellent response, as most people do with the first-line TKIs. Had very significant skin toxicity, requiring multiple dose interruptions and dose reductions, even down to levels at 50 milligrams needed to have dose interruptions. So it was pretty profound for this patient. And as what happens in most tumors, this tumor progressed in the left rib, had increasing pain. We decided to continue the erlotinib and do radiation to the rib to see if we could get benefit and continue on the erlotinib. And that did not have significant benefit, and then there was growth in the pleural effusion and increase in symptoms. So we sent him to do a repeat biopsy and had found a T790M mutation in the left lung tumor. So at that time, we had a clinical trial with CO1686, and immediately within 2 weeks, he was feeling better. His pain, which had been a problem for months, was almost gone, and he had a partial response with about a 60% tumor reduction. And so these are his pre-scans on top. And so you see kind of multiple areas. A lot of this is along the pleura. And then the post on the bottom, and I think the most evident are is the tumor in the middle, in the lymph node, and the tumor along the pleura, which in one area had totally resolved, and the area that was pressing into his rib and causing his pain had totally resolved. And so he continues on that therapy now. You don't want me to take any questions, right? Yeah, okay. So moving on to ALK, acquired resistance. This is a 52-year-old female who presented with neck discomfort. She got a chest x-ray that showed a deviation of the trachea, and this was because there was a large thrombus in her right internal jugular vein, had multiple lymph nodes in the middle of her chest, and a 1.9 centimeter right lower lobe mass. She had a PET CT that showed increased uptake in the right lower lobe and the multiple lymph nodes in the mediastinum, and a right supraclavicular lymph node. She had an MRI of the brain that showed no evidence of metastatic disease. She had a right lung biopsy that showed a moderately differentiated adenocarcinoma. TTF1 was positive, CK7 positive, and CK20 negative. The right supraclavicular lymph node also was biopsied and demonstrated a poorly differentiated adenocarcinoma. She had molecular testing, and EGFR and KRAS were wild type. ALK was translocated by FISH. Her TNM stage at that time was T1A and 3M0, and stage 3B. And therefore, and this is one view of her tumor at diagnosis, the main tumor in her lung. And she was treated with concurrent chemotherapy and radiation. And that's because this was, when we have a stage 3B, there's still a definite, though small, chance for cure with chemotherapy and radiation. So she was treated with concurrent chemotherapy and radiation, and in early 2013, unfortunately, the tumor progressed relatively rapidly, and because we had the ALK information, she initiated on crizotinib pretty quickly. In about a year later, she presented actually with a life-threatening disseminated intravascular coagulopathy, and had a bleed in her brain, and so the tumor wasn't that evident on imaging, but systemically she was decompensating, and it was really growth of the tumor. So over this hospitalization, the tumor did start to grow in the lung and multiple abdominal lymph nodes, and so she was started on, this had to be done really urgently, so she was started on pemetrexed, and got 8 cycles, did really well, had a great response to the pemetrexed, and improved and had no other issues with the bleeding, but then developed progression in pelvic lymph nodes and had significant lower extremity edema and discomfort from this. Her chest was relatively clear. She started on treatment on a phase 2 trial with brigatinib in November, and at this point has a complete response and no evidence of her tumor. So this is one of the main areas pre-treatment, and that's one of the large lymph nodes that you see that's circled, and it's essentially resolved. And that was after 8 weeks on brigatinib. And then the last case is control of resistance in the brain, and I think this is one area where we're really evolving, and whole brain radiation is difficult at best, and if we can avoid it, it's always my preference to avoid it. Sometimes you can't, and there's just too many tumors to do by gamma knife or by SRS. But the other piece of this is that when we talk about whole brain radiation and lung cancer, we're used to treating people who are relatively older in age and have more limited lifespans. When we talk about oncogene-driven tumors, we're talking about people who are usually working and functional and doing a lot of things in their life, and generally younger. And doing whole brain radiation is something to really take seriously before embarking on it. So I think now that we know that we can have control in the brain, and it's an exciting time for patients and physicians who treat them. So this is a 30-year-old who had 3 months of progressive cough in 2012. She was evaluated and admitted and was found to have a large pericardial effusion and bilateral mediastinal lymphadenopathy and metastases to the bone. She had a pericardiocentesis and pericardial window. She had pathology that showed adenocarcinoma, CK7 positive, TTF1 positive, and with molecular evaluation was done for EGFR and KRAS, which were wild type, and ALK was positive by FISH. MRI of the brain was not performed at diagnosis, and her stage was TX and 3M1B. So she initiated on crizotinib and had an excellent response, had minimal toxicity, and had been living her life. The tumor progressed in mediastinal lymph nodes in the fall of 2014, and at that time, in order to continue the crizotinib and continue benefit, they did radiation to her chest, and that was done in January of 2015. At some point in the beginning of the year, she developed some lightheadedness and syncope, and had a syncopal event and had increasing headaches. So an MRI of the brain was done. It showed multiple lesions in both cerebral hemispheres, the largest in the frontal lobe, and there were 2 parietal lesions and an occipital lesion, and she was relatively symptomatic from this. So she was started on steroids and improved some, but still continued with a number of symptoms. She had a PET CT that showed low-level activity in the mediastinum, but for the most part, she had no measurable disease in the body. This was only a brain recurrence. So it was recommended that she get whole brain radiation, and that's when we saw her. So we first sent her to surgery, and she had a craniotomy with resection of the 3 largest lesions in order to try and control her symptoms. And then she discontinued crizotinib and started on a trial with X396, which is another second-generation ALK inhibitor, and it's now status post 2 cycles with brain response. And because she had the surgery on the largest ones, it was hard to find pictures that kind of show this response, but the large one that is circled on the left is pre, but that one was resected, and there was evidence of disease in the midline, and that has improved. And so now she continues with response and has been able to avoid whole brain radiation. And I think more and more we're seeing most of these patients can get there. The last case is de novo resistance and alternative options. So this is a 50-year-old woman who had progressive right neck swelling back in 2007. She had a biopsy and a CT scan. She had a CT scan of the chest that showed a 2.6 centimeter right supraclavicular lymph node, mediastinal lymphadenopathy, and a 1.2 centimeter right lower lobe nodule. She had a biopsy of the supraclavicular lymph node, which showed adenocarcinoma, and also the lung too. They were TTF1 positive, CK7 positive. She had an MRI of the brain, which was negative for metastatic disease, so she had T1A and 3M0 disease, and she received, and this shows you kind of the majority of the disease at baseline in addition to the neck node. And she received concurrent chemotherapy and radiation, standard, in early 2000 and completed in early 2008. She was followed closely with the thought that maybe this could be a cure, but lung cancer is a wily thing. And in 2012, she had recurrence of the right lower lobe nodule. And the PET CT showed only uptake in that nodule, and MRI of the brain was negative, and the biopsy demonstrated adenocarcinoma. And so she went to surgery and had a right lower lobectomy. Lymph nodes were negative at that time for recurrence. And again, we thought she was cured. We did molecular testing. She was found to have an exon 20 insertion in the EGFR gene, which tends to portend to de novo resistance to EGFR TKIs. So she was monitored off therapy, and and 2 years later developed metastatic recurrence in multiple lymph nodes within the lung. And again, the biopsy showed the recurrent adenocarcinoma with the exon 20 insertion. So this is the same tumor. This is showing some of her metastatic progression. As you see, it's in many, many lymph nodes. So she was actually evaluated for another clinical trial and with an anti-PD-L1 antibody, and she had PD-L1 expression on her tumor and was able to initiate on the trial as first-line systemic therapy. She initiated in May of 2014. The tumor progressed actually in the right axillary lymph node, was biopsy proven to be adenocarcinoma, but continued on therapy post-progression because she was asymptomatic and remains on the therapy without further progression to this day. So what I just want to impose upon you is that resistance is complicated. Almost all lung tumors that are oncogene-driven develop resistance at some point. And we really have come a long way over the past 5 years in understanding the types of resistance and developing drugs to attack the resistance that we see. And we do have great next-generation TKIs that show promise, and potentially immunotherapy. In what sequence, in what combination, we don't know. But I think there are great reasons for hope in the area of resistance in oncogene-driven tumors. And then I take this, we've exhausted all conventional measures. One last desperate option is to put you on an alternative medicine that has a 96% success rate. And this is what we've seen with patients, is that they go on to something when there seems like there's little left on these phase 1 trials, and there's spectacular responses. And we need to keep hoping for that, or keep working for this. Thank you.